So the people there will be the people who are the exposed will be there, people who are unexposed will be there, people who had the disease and without the disease, and the normal population also, all in one go. If we study, that is called a cross-sectional study. Now, let's enlarge this bit for you. First thing is you ask, did the investigator assign exposures? In COVID, could we assign exposures? Have one group will expose to COVID virus, another group we don't want to expose. It's not possible. It is not ethical. In certain other situations, like amlodipine, cilnidipine question, we can expose half of them to cilnidipine, half of them to amlodipine. Then that becomes an experimental study. Whereas in COVID, we are not supposed to do an experimental study with the COVID virus. We can't give exposure and no exposure. So we have to observe. So when there is an observational study, means we are not giving the exposure, which is not under our control. These are called the observational study. The study I just now told, like the antibodies in COVID exposed and COVID positive and normals, look at them as an observational study. Then the question is there a comparison group? If there is a comparison group, that means you have people who never had any exposure, people who had the disease, people who had neither, and there are comparison groups are there in that question. If the comparison groups are there, it becomes an analytical study. If there are no comparisons, I just wanted to look at the antibodies only in the COVID positives, then it becomes a descriptive study. Understand? The terms observational and experimental are decided on whether the exposure is under our control. If the investigator is having the control of the exposure, then it will be experimental study. If it is no control, it becomes observational. In the previous paper, they did the test specifically. They did this test and that test because it is in their control. They had to test this and that. So they are not just observing how that test performed, the A/B test compared to other tests in a population there. So there is an experiment involved. Experimental study, observation means there is no experiment possible, only you observe. Initial studies are usually observational, hypothesis is generated. Once the hypothesis is sound, then we go for the experimental study. Okay, experimental study in a COVID could be, half of them receive plasma therapy and half of them may not receive plasma therapy. Half of them may receive vaccine, half of them may not receive vaccine. Half of them may receive remdesivir, half of them may not receive remdesivir. Like that, the experiment is possible because there is an established treatment, so you are trying to compare the different treatments. In such a case, it becomes an experimental study. Observational means no experiment is done. Simply we have studied all people given remdesivir, how many of them recovered, how many of them died. That is an observational study. If there is a comparison group in your own hospital, you just take people who took remdesivir, who also did not take remdesivir or not given remdesivir, and use a comparison group. That is a comparison study. Again, if there is no comparison group, it becomes a descriptive study. If there is a comparison group, it becomes an analytical study. Okay, if there is a comparison group, it becomes analytical. No comparison group, descriptive study. Observational studies can be, first of all, cross-sectional, very low standard. They're not going to really throw anything. They only give you an idea about the problem. Descriptive studies are good in the initial phases, but they do not answer the questions. Then you have to go for analytical study. You should have a comparison group. Supposing I wanted to know diabetes and fatty liver, I can't just have only diabetes and fatty liver. I should also have people who do not have diabetes and look for fatty liver and compare what is the occurrence of fatty liver in non-diabetics compared to diabetics. Then the study becomes robust. So you understand the idea of comparison group. So the analytical study, then the direction of inquiry. That means, are you proceeding from disease to the exposure, or are you proceeding from exposure to the disease? For example, the people who had diabetes, we prospectively followed for 5 years. How many of them developed diabetes in the course of prospectively in future? That is called the exposure is diabetes, outcome is fatty liver. So exposure is earlier and outcome is occurring later. That is a prospective study, also called the cohort study. In such a case, we assemble, say, 100 patients of diabetes, 100 or 200 non-diabetic, and allow them for 3 years or 5 years and look, and all of them are no fatty liver to start with. Everybody is negative, but they have diabetes, no diabetes. Follow them for about 5 years or 3 years and see how many of them develop fatty liver. in the diabetic group, compare the non-diabetic group. Such a study is in the prospective direction, that is called a cohort study. The other way around, we go to the ultrasound department and then ask all the patients who had fatty liver, get those records, and then decipher them into those who had diabetes for 5 years and those who did not have diabetes, and compare them. That is a case control study. So those who did not have diabetes and those who had diabetes after the disease has already occurred. Here in the second case, the disease has already occurred. We are retrospectively going into the records and looking at the records. So that is a case control study. In this case control study, for example, for the same thing, you go to the radiology department, take 100 people with normal scan, 100 people with fatty liver, and then see the diabetic population in both the groups. That becomes a case control with a comparison group. Cross-sectional study we already discussed, where the exposure will be there, the outcome also will be there, and normals also will be there. These are very low in the rigor of methodology. So basically, what did we understand? Studies can be, depending on whether the intervention is under your control, is it observational or is it experimental? If observational, is there a comparison group? If yes, it is analytical. If no, it is descriptive. In the experimental, can a random allocation be done? So if you can do a randomly allocate, then this is a randomized control trial. Non-randomized control also we have to do. So, supposing I say I wanted to compare, in two interventions, let's say surgery versus medicine, then, instead of a randomized trial, I may even go for a sort of non-randomized design. So it depends on the question whether what we choose. Now, basically, what did we understand from this slide? Is the exposure under our control? If yes, it is experimental. If not, it is observational. Under the observation, is there a comparison group? No, it is descriptive. And if there is a comparison group, it's analytical. And what is the direction of inquiry? Is it from exposure to disease? Cohort study. Disease to exposure back, that is a case control study. All three are there, and then one go you just do it. It is a sort of cross-sectional study. So,
research methods.
First of all, the case reports, individual case reports, and case series, cross-sectional, and then case control studies, retrospective, and particularly for causation, cohort studies like prospective, longitudinal, incidence studies. Then you have the experimental studies, particularly uncontrolled, non-randomized trials, and you also have randomized control trials. Okay. Now, so the weakest will be the observational studies like a case report. Let's say I published 4 cases of any disease, COVID, from my hospital. This is a very weaker evidence compared to I did a study using an experimental method controlling the intervention with plasma, without plasma, or with remdesivir, without remdesivir. 2 groups are compared, and that is a more robust study. So the weakest will be the observational studies, case reports, case series. As you go down, the rigor will be increasing, and the strongest will be randomized trials. Having said that, in all the cases, randomized trials will not be possible. So in such a case, we have to resort to uncontrolled non-randomized. So you see here, in the cohort study, the exposure, people who had COVID, who did not have COVID, outcome, how many had developed antibodies or no antibodies. So the exposure to outcome we are seeing, which is a cohort study. People who have diabetes, no diabetes, how many in the diabetics developed fatty liver, how many in the non-diabetics developed fatty liver, is the exposure to outcome, forward direction, prospective direction, called the cohort study, called prospective study. So they said there's a prospective study because they recruited patients prospectively and looked at that. Here, retrospective here, people who had exposure, but we are looking at the people who already had the outcome. We are looking at the exposure in a reverse way. That means people who had antibodies and people who did not have antibodies, and look at how many are exposed or unexposed. Or people who had fatty liver, who did not have fatty liver, how many have diabetes in the people with fatty liver, and how many are the people in the non-fatty liver had diabetes. This is a look at the retrospective study or the case control study. In prospective study, we go from exposure to outcome. In retrospective study, we from the outcome to the exposure. This is also called the retrospective study. Now, Research questions on burden of illness, prevalence, incidence, your appropriate study design will be field survey, cross-sectional survey, or longitudinal. Suppose you are working on a disease causes, risk and prognosis, you do a case control study or cohort study or an RCT. Diagnostic evaluation, please mute your microphones, all of you. Treatment efficacy, randomized control study. Cost effectiveness studies, randomized control studies. Depending on the question, the study design can be taken. So described as occurring in nature, observational study, or if you allocate the exposure, exposed and unexposed, and go for the outcome, then the ethics has to permit that, and allocation to randomized trial, observational versus clinical trial. This is the difference. Cohort study, people who had diabetes, who did not have the diabetes, exposed and unexposed to diabetes, how many of them had developed diabetes with the outcome, how many without the outcome, without diabetes. Likewise, in the non-diabetic population, how many of the exposed people, how many are diabetic, and out of them, how many are developed fatty liver, and who without outcome means how many did not develop fatty liver. In the unexposed group, that is non-diabetic, how many had fatty liver compared to those how many did not have fatty liver. So the direction of inquiry is forward. Question is what will happen? What will happen if somebody has diabetes or no diabetes? Will there be fatty liver or not? That is the question is there. Whereas in retrospective study, you have the cases who already have fatty liver and you have controls who do not have fatty liver, and go and look back how many of your cases are diabetic and how many are non-diabetic. Likewise, in controls, you go back and see how many of your non-fatty liver people are having diabetes and not having diabetes. The required direction of inquiry is backward. This is called case control design. Here the question is what happened to the people. There what will happen in future. Here what has happened to those with the fatty liver, without fatty liver, as far as the diabetes is concerned. Now, clinical trials, there will be phases, because phase 1 trial, you will be hearing the vaccine trials are there. In third phase it has entered, second phase entered. Usually normal volunteers, small group safety testing. Phase 2, does it help the patient on patients to confirm the effectiveness of a drug? Phase 3, is it any better in large groups for statistical confirmation of the effect and side effects and all that. So most of the vaccine trials are in phase 3. Phase 4, does it really work in the community? That means the vaccine is already, let us say, is given in the community. The post-marketing surveys or post-vaccine studies, they're all the phase 4 trials. Most of our vaccine trials on COVID are in the phase 3. Now, random assignment is take the population of patients and randomly assign to intervention A, intervention B. For example, let us say a population of patients of COVID positive who are admitted to GEMS hospital, that is the population. I randomize them, half of them receive convalescent plasma, half of them do not receive convalescent plasma. Intervention A is convalescent plasma, intervention B, no convalescent plasma. But you have to keep all other treatments same, like your remdesivir giving or your low molecular weight or your oxygen, all those things will be same except for the plasma. This is called a parallel design. Parallel design. Other thing is crossover design. What will happen is, so there will be two drugs, A and B are compared, cilnidipine versus amlodipine. First of all, I assign to cilnidipine A and amlodipine B. After 3 weeks, I change the drug. B will get cilnidipine now and A group will get the amlodipine. That means they will act as an internal control. This is a very powerful design, provided the disease permits to do a crossover. So there are multiple levels of randomization. First level, you can randomize them into A and B and take A and then further randomize them into C and D and take B and again give them C and D. For example, I tell you, you have COVID patients, population have a random remdesivir A, no remdesivir. Among those remdesivir have plasma, no plasma. Again, among those without remdesivir have plasma, no plasma. Like that is called a factorial design. So what did we learn now? We have learned what is a parallel design. We learned about the different phases and also all the different trials. We have learned prospective study, we learned retrospective study, we learned. We also looked at the different phases of clinical trials. We also looked at a parallel design of random assignment. We also did a crossover design of random assignment. We also looked at multiple levels of randomization, which is called a factorial design. And then, for example, a factorial design, an example is given, population of 22,000 is taken, 11,000 are sent of aspirin, and 11,000 to placebo. This is actually a study that is done in 1985. I'm showing you here a physician's health study, PHS it is called. And those who had aspirin, half of them had beta carotene, half of them had placebo. Like with the placebo group also beta carotene and placebo. And this trial proved that beta carotene addition is not going to do any better whether you are given aspirin or placebo. So the beta carotene is no more used. We only use aspirin. Aspirin is much better than the placebo in that particular population to secondary prevention of coronary artery disease. So this is the actual study that has happened. So this is a factorial design. So advantages of randomization are ensures comparable groups, ensures relationship of the cause effect, known and unknown are equally spread, statistical tests have all the validity, generalizability is more, hard to recruit and complex of course, patient and physician resistance will be there. Supposing I tell my patient I want to randomly give you plasma or no plasma, no sir, I know I have read in paper, plasma is going to work, why are you putting me in the placebo group? He may not agree for randomization. So what we have to do is, we have to be ethical and consider those things. Complexity also sometimes. So here, the randomization study designs will have those things. Gold standard versus new treatment, standard treatment versus new treatment, normal versus higher dose, low dose, higher dose, dose titration, treatment versus placebo, historical controls versus present treatment group, stratification to base on the different confounders. I'll tell you what is confounders in a later part of the story in tomorrow or day after. And for the moment, you just understand that types of control groups that you take. So there will be a standard treatment and a new treatment, or a low dose, high dose treatment. 100 milligrams, 5 days of remdesivir compared to 10 days of remdesivir is a sort of dose titration. And again, treatment versus placebo, plasma, no plasma, historical controls, those who were treated in the hospital earlier without plasma compared to present group who are treated with the plasma. Compare these two groups. And in February, March, April, we have not given plasma. May, June, July, we have given plasma. Compare the historical controls. They're slightly weaker there. And of course, the strategy. Analytical methods, when we come to that, I will show you that. Analytical studies are, the key word is comparison. Whenever we say analytical study, there are two groups minimum. Sometimes there will be more than two groups also. Those who had the exposure and without exposure, and follow them up for a period of time. So if that in the denominator, if the numerator also is included, that is, you have 100 people who have died, and out of 1,000 people who are admitted. Where in the denominator also included people who have died and not died. So it is included, then it will be yes or no. If it is no, then it becomes ratio. So 100 people have died, 1,000 people are admitted. 100 by 900 will be ratio of death. Supposing I want to know the gender ratio in the students who are admitted as PGs here. Just count the number of people, and there are 50 male students, and then there are 45 female students. 50 by 40 is to 45 is the ratio. When the denominator does not include the numerator, then it is a ratio. When the denominator includes, that means there are 100 students admitted in the college, 53 are boys and 43 are girls. 53 by 100, 53% will be a sort of, it's not a ratio, it is a rate. When you say a rate, the denominator is included in the, numerator is included in the denominator. Whereas when you say a ratio, the numerator is not included in the ratio. The best example is 53 girl students versus 47 male students. 53 is to 47 versus 53 divided by 100 will be the rate. That will be the rate. Okay, rate can be incidence rate, case fatality rate, prevalence rate, several other things, rates and proportions. For example, case fatality rate. In GEMS, there are 1,000 admissions have happened in the last 3 months. How many people died in the GEMS? That becomes the case fatality rate. There are 100 people died, 1,000 people admitted, case fatality rate is 10%. In another hospital, 50 people died out of 1,000, the case fatality rate is 50. Why these two are different? Because they admitted milder cases, here severe cases are admitted, whatever may be the reason. That is the case fatality. Mortality rate is in the community. So you can see now the COVID mortality was around 2.5%. Today it is around 1.4 to 1.5. Means number of people who died due to COVID divided by all those people who are tested positive in the community. The denominator is not only hospital people. Everybody who is tested positive in India is in the denominator. So then the numerator will contain the people who have the COVID disease. That is called the community fatality rate. Then supposing we put the India population below and the number of deaths of COVID on the top, then that becomes the COVID mortality rate. That is the general mortality rate. Cause specific mortality rate, you keep COVID cases in the bottom and then COVID deaths on the top. General mortality is keep all the population in the bottom and keep only the COVID cases on the top. So these are some of the rates and proportions which you require to know. A retrospective design and prospective design. So we will come to that a little bit when we go to the case control designs. Anyway, you understand in retrospective design, there are cases and controls. Cases here are people who had fatty liver in the ultrasound, people who did not have fatty liver are the controls. And then how many of my cases had diabetes exposed? How many of my cases, that is fatty liver people, are not having diabetes unexposed? A is exposed and cases, C is cases who are unexposed, who did not have the diabetes. Controls are people who had already, who did not have the fatty liver. How many of them had diabetes? That is B. And D is how many of the people who are not having fatty liver, but also do not have diabetes. That is D. And the totals will be A plus C here, B plus D, like that. Odds ratio calculation, OR is equal to A by C divided by B by D, or cross multiplying AD by BC. When I give you the example, you will be able to understand. Whereas when you do a retrospective analysis, for example, here lung cancer and smoking, there were total 110 people with smoking, 130 non-smokers. There were 240 people are taken. Out of those who had lung cancer, 80 people were smoking. Out of those with lung cancer, 40 people were not smoking. So A by C will be 80 by 40, whereas controls, 30 people were smoking among the controls who did not have lung cancer. And then 30 had no smoking in the control group. 30 by 90 will be in the control group. A ratio of them is what is called the odds ratio. In other words, 80 multiplied by 90 is 7,200, 30 multiplied by 40 is 1,200, 7,200 divided by 1,200 is equal to 6. The odds ratio greater than 1 is high. Here in this case, very high, says that lung cancer is associated with smoking. This is a retrospective design. When you go to a prospective design, you will have here we start with exposed people, that is people with diabetes. A plus B people had diabetes. Out of them, A had fatty liver. Likewise, C plus D people had no diabetes. Out of them, C had fatty liver. So A plus C people are in total had the disease A by A plus C, A by A plus B. That is out of the people who had A plus B people who had the diabetes, A people only developed the disease. That A by A plus B is the incidence of fatty liver in the diabetics. C by C plus D will be the incidence of fatty liver in the non-diabetics. And a ratio of them is what is called the relative risk. So what I understand now, whenever there is a case control design, we do an odds ratio. Odds ratio is AD by BC. Whenever I have a prospective study, we have to do a relative risk calculation. So we'll take examples and do it. For example, there is a hostel and people who had the students, there are 100 students and 33 of them have taken biryani on Sunday night, big bada khana, they were served biryani. Out of those 33, 23 people developed diarrhea next 1 to 2 days. So 23 out of 33 is the incidence of diarrhea in the biryani group. Whereas 67 of the students, they have not taken biryani, but 7 of them also developed diarrhea. So 7 by 67 is the incidence of diarrhea in the non-biryani group. Then if you want to compare them, 23 divided by 33, that ratio is divided by 7 divided by 67. Incidence in the case group divided by the incidence in the control group is 6.67, which is a very high relative risk. Says that it is the biryani which probably has caused the diarrhea. So this is a prospective thing. Biryani taking has happened this night and we looked for the diarrhea 2-3 days later. So this is a prospective design. So this is the calculation that there is also what is called an attributable risk. Attributable risk is you just, in the earlier case, you divided one by the other. The 22 divided by 33 is divided by 7 divided by 67. That is incidence in the exposed biryani group divided by the incidence in the non-exposed or no biryani group is the relative risk. If you subtract that one from the other, incidence in the biryani group minus the incidence in the non-biryani group, that becomes an attributable risk. So the three concepts we understood. One is the odds ratio in case control study, and the relative risk in the prospective studies. Attributable risk is one subtracted from the other, and relative risk is one divided by the other. So this I will skip, and I'm going to give you a sort of worksheet which you will fill it up now. And I request Dr. Pattnaik and Dr. Samata and Dr. Other doctor and Nagaraju to distribute the worksheet, which is 2-page worksheet. So please go through that and then fill the answers based on the presentation that I made now. Okay. If you have any doubt, we will discuss that. For the benefit of those who are online, I am projecting this questionnaire online so that you can read and make up your mind and work on that. So part of it is already covered in your previous this one. So the first finer, you know what is finer. Again, just to recapitulate, I have given you that finer, F-I-N-E-R, finer, feasible, innovative and novel, feasible, interesting, novel, ethical, and then relevant. So remaining parts you answer. Name any 4 types of study designs for medical research. Name any 4 types of designs. Whatever you have just learned. Answer these. We will go to the answers of this, and then at the end we will see. Those who are the offline people, so online people, they can just see the document here, and I am just keeping the document to a size where you can read all the questions. There are some on the next page also. I will show you them later. So I'm starting from question 2 for you and to question 10. You please read the questions and answer for yourself. If you have seen the first page, I would scroll for the second page for those who are here. I think the second page is not covered already, so we will only stick to the first page. All of you, please stick to the first page only. Second page of it will be answered tomorrow. Okay, just let us answer only the first page, because second page questions are not covered, so don't worry about them. Up to 8 only you answer. Up to question number 8. 9 and 10 also are not covered. Sample size and medical research measurement is not covered. Only answer questions up to 8. 1 to 8 only. Dr. Samata madam and both the professors, if they are through, we will discuss these things. Hardly 8 questions, 7 questions. Tell me if they are ready. Yeah, we'll maybe I'll spend a little more time on odds ratio and thing, because a little difficult to calculate. I'm also opening my video so that they'll be able to see and listen. So, what are the name 4 types of study designs? That was the question. What are the 4 types of study designs? Cross-sectional study, very weak. Case control studies, okay? Prospective cohort studies, randomized control trial. Isn't it? 4 important study designs are descriptive studies, under which cross-sectional, analytical studies, under which you have the case control and the cohort. Descriptive, there is no comparison group. Analytical, we have a comparison group. Analytical means always you have a comparison group. There will be cases and controls, or there will be people who are exposed or unexposed. If you start with exposed and unexposed and look for the outcome in future, it is a prospective study. If you start with the disease already occurred and without disease, with and without disease, and look back into behind, that is a case control study. Whereas when the exposure itself is under your control as the experimenter, amlodipine versus cilnidipine, or plasma versus no plasma, or plasma plus remdesivir versus no plasma alone, whatever comparison you want to make, then that becomes a experimental study. Under that, non-randomized and randomized. isn't it? So the types of study designs are, first question is there any exposure under our control? Or is it naturally happening in the community? Sometimes you cannot control the exposure. Sometimes you cannot give the experiment. For example, I can't study, hepatitis B to half group. I can't give the virus and not give to the other to see what happens to the liver. I can't do that. This is unethical. Nature, suppose it experiments. And likewise, now I want to study the effect of smoking and some disease, lung cancer. I can't ask half of my people, you all smoke and you don't smoke. Like that, I can't do that. It is unethical. So in causation, usually, experimental studies are not possible. In treatment, they are possible. Standard treatment versus new treatment, lower dose to higher dose, two interventions versus one intervention, surgical versus medical, all these can be possible. Whereas in causation, usually experimentation is not possible. In such a case, what do? I go to the non-experimental design. What is non-experimental design? Is there a comparison group? No. Then it becomes a descriptive study. If there is a comparison group, then it will be either a prospective study where I take the exposure in question and assemble people with the exposure, smoking, without the exposure, non-smokers, and prospectively look for 10 years how many of the smokers developed lung cancer compared to non-smokers. This is a kind of prospective study where you do only a relative risk. What is the relative risk? Relative risk is the incidence in the exposed group. That means among the smokers, how many have developed lung cancer? That is the incidence in the exposed group compared to the incidence in the non-exposed group. Incidence in the non-exposed group, how many among my non-smokers developed lung cancer? You just use these two incidences and one divided by the other is a relative risk. One subtracted from the other is a attributable risk. Okay. I don't have the time to assemble people now, smokers, non-smokers, wait for 10 long years or 15 long years, see how many of them really develop smoke and lung cancer or not. Then the time is not at your disposal. Then you can do what is called a case-controlled study, where you assemble patients of lung cancer, comparable patients without lung cancer, and look at the smoking history in those with the lung cancer, compare that with those without the lung cancer. Such a study is called a retrospective study. It is less vigorous, but less time consuming, less resource consuming, faster, and it tests the hypothesis quickly. Particularly causation, case control studies are quite good. Okay, having said that, what is the measure I do it here? It is not the relative risk. It is the odds ratio. What is the odds ratio? Odds ratio is I have cases of lung cancer. What is the rate of people who are smokers among the lung cancer compared to rate of smokers in the non-lung cancer? A by C here and B by D there, and a cross multiplication of them is the odds ratio. And the other study is randomized control trial. I have told you several examples. Cilnidip in one group, amlodip in another group. Prospectively treat them for 3 months, 6 months and find out. Or plasma for one group, no plasma for another group. Wait for 15 days for the outcomes and then see what happens in the COVID. Such a design is called a experimental study. If you randomly do it, randomize it, then it is a randomized control trial, which is the most robust. Always not feasible. Whereas, now the third question is cross-sectional studies, are they experimental or analytical? Cross-sectional studies are experimental. They're not experimental, isn't it? Cross-section study, you are not doing any experiment. As it happens, how many people in Srikakulam have hypertension? Suppose I wanted to know that. Then take a sample of Srikakulam population, 20,000 people, and look at hypertension and titrate different age groups, gender and whatever it is. And that is a cross-sectional study. One time where you have the normals, you have people with hypertension, people without hypertension, whatever is the factor you are looking, it is a non-experimental design. The answer there is cross-sectional studies are experimental, answer is false. Next. In case control studies, we work forward from exposure and no exposure towards disease and no disease. No, If we work forward, it is called a prospective study. In a prospective study, we take people with smoking, without smoking, and look for lung cancer, no lung cancer in a future time. Whereas in a retrospective study, we don't do that in a forward manner. So the answer for that question is false. Cohort studies, we require prospective follow-up for a long period of time for the outcome to occur. Very much true. Because supposing I wanted to know the lung fibrosis in COVID patients. Okay, COVID is supposed to produce pulmonary fibrosis. How do I do that prospective study? Take 100 people who have survived from COVID, mild, moderate, or severe, whatever it is, and then take normal people also who have never had COVID and prospectively see how many of these people develop lung fibrosis in those without COVID versus mild, moderate, severe COVID, how many develop in future. It takes a long time to do that. So that's what the question is asking. Prospective studies, a longer period of follow-up for the outcome to occur. Yes, it requires longer period of follow-up, more rigor, more resources, more time and all those things. The best study design for ascertaining the efficacy of a new treatment. So I have a new treatment for COVID. Let us say GEMS people have detected that one particular drug is working compared to others, and we want to test that. Nitazoxide, yesterday, Lancet it is published. Nitazoxamide is a new drug supposed to be working for COVID. How do I do that? I take COVID patient, 50% of them, I put them on the standard treatment, what is being followed of them, and the remaining 50% I add nitazoxide also in addition to that and compare them randomly. A randomized control trial will be the best way to ascertain the efficacy of treatment. Case control, certainly not. Cohort studies are possible. When we cannot randomize, we can do cohort studies. For example, vaccine trials. We wanted to know vaccine A and vaccine B. One is the mRNA vaccine, the other is the conventional vaccine from the sort of, attenuated vaccine. You give half of them mRNA vaccine, half of them attenuated vaccine. Randomly you allocate into 5,000, and look at the protection rates or antibody rates. And then it's a prospective study or randomized control trial. Non-randomly also you can do a prospective study. Whereas for treatment, I have treated 4 patients with aspirin. Aspirin worked well, a case report doesn't work. You should not use case reports for efficacy. Likewise, case control studies, anecdotal experiences. No, we are using garlic, and all those people who had garlic, they did better. Where is the study for that? Turmeric is very, very useful. Maybe useful as an antiseptic. How do you prove that? You have to have a randomized trial or at least a cohort study to say that. Not the cross-sectional, not the case report, not the case control. The best study design, of course, is RCT. If RCT is not feasible, if you cannot randomly allocate the treatment, then probably you can have a cohort study. What is a double-blind randomized control trial? I did not explain you, now I am explaining you here. Double-blind means not the blind people working 2 types, not that. Blinding is with result to the exposure and the measurement. Supposing I have a vaccine trial, placebo versus the mRNA vaccine, of the Pfizer mRNA vaccine, I wanted to do the trial. I will not be knowing, the investigator will not be knowing who received the placebo, who received the vaccine until the end of the study. When the code is broken, then only we. This is blinding on the part of the investigator. The other blinding is patients also will not be told that they received whether placebo or the mRNA vaccine. So that is called the double-blind design, where the patient is not knowing what vaccine he got or placebo he got, or what if it is you're using different doses, whether lower dose or higher dose, or if you're comparing 2 interventions, and intervention A or intervention B, that information is not available to the patient. Likewise, investigator also is unaware. Why this required? For bias. So for example, if I tell the patient that he received the vaccine, and another patient, I tell the patient he is not received the vaccine, only placebo. Even the patient who received the vaccine may complain all sorts of side effects. Sir, I had fever, I had swelling, I had induration, I had diarrhea, I had headache. How do I know whether this is more compared to the placebo? So the bias will occur. In order to remove the bias, we will not tell them whether it is vaccine or placebo. Whereas the investigator also, while assessing, oh yes, he has received vaccine, must be he has improved, must be antibody titers must be, I have a bias. Whereas when somebody has received vaccine, no vaccine, the placebo, and I will say, no, he has not received vaccine. Probably this will not work for him. So this investigator bias. In order to remove the investigator bias, investigator prejudice, patient's prejudice, we have what is called blinding is done. This blinding for RCTs is very useful because it ensures comparable groups, it increases the validity of the statistics, it increases the reduces the confounding effect and increases the chance of, no, it decreases the chance of bias. So the answer here is all except. It does not increase bias, rather it decreases the bias. What is bias in that case? Bias is a pre-decided, preconceived notion that something works or doesn't work, either by the patient or by the investigator. There will be sometimes what is called a triple blind design. What is triple blind design? Triple blind design is even the person who is assessing the outcome is different from the person who is treating the patient. The person who is treating does not know. The person who is quantifying whether he had cough, fever, or headache, or body pains, or antibodies, there is a different person. He also does not know which is vaccine and which is placebo. So there is an investigator, there is a patient, and there is an assessor. Three are separate, and three, they don't communicate about an individual result. But once the study is completed, they open the codes and see how many in the vaccine group had the problem, how many in the non-vaccine group have improved or had the problem. And that is a sort of a triple blind design. Usually double blind is adequate. For example, blinding is not possible. For example, I am testing surgery versus medicine. How can I blind the patient from surgery? I have to, when I do a surgery, I can't do a placebo surgery and just open the abdomen and close it without doing the proper surgery. That is unethical. So the patient is bound to know that it is surgical or medical treatment. So you cannot blind in certain situations. In that case, what we do is, we had a study in TB spine, in TB Research Center in 1980s and 70s. Then we had surgical versus medical treatment for tuberculosis spine. So obviously the patient knows and the investigator also knows, but the assessor who is looking at the improvement in the X-rays, who is improvement in the other, this one, they were not given the information whether they had surgery or not. So that way we have ensured some amount of non-bias in that. That study ultimately proved that medical treatment is very effective compared to as effective as surgical treatment when there is no cord compression. Without cord compression, nobody does the surgery for tuberculosis spine. Today, that is a landmark trial which proved the world that medical treatment of 9 months with anti-TB drugs is as good as surgical treatment. Prior to that, a lot of surgical treatments were being done. So that was given up after that study. That's how the studies will be very valuable in producing beautiful results. So now, number 8, in a study involving comparison of surgical and medical treatment, a double-blind study design, this I already answered this, it is not possible because double-blind is not possible. Assessor can be blind, but the investigator and the patient will know whether surgery is done or not. So these are the answers to some of the questions. And ponder over the presentation. I will give you the presentation. Look at the odds ratio and the relative risk calculations in your own mind. And tomorrow when we assemble, probably we will take one problem as the first thing in the thing and then solve that problem of odds ratio and relative risk and then go ahead for the rest of the discussion. Now I open it for the questions from the students and my co-faculty. Is there anything not understood? Another 5-10 minutes we can spend because we started at 10:10, so nearing it's 12 o'clock. So up to 12:15 we can keep the session open. Then we will wind up.